Thank you, sir. Thank you, Chair. Thank you, Ceylon College of Physicians, for giving me opportunity to present in the Young Physician Forum. So this is my topic, thrombotic microangiopathy, decoding its complexities to aid in clinical management. So I first start with few cases which I have encountered in the past. Case 1 is a 63-year-old, previously healthy male, presented with bilateral frontal headache and facial pain for 6 weeks duration, with associated shortness of breath and bilateral lower limb skin rashes. On examination, patient was not pale or icteric. He had tender sinuses and skin lesions were suggestive of cutaneous vasculitis. Rest of the examination was unremarkable. He underwent rigid nasal endoscopy, which showed necrosis of the sinuses with foul-smelling discharge. His inflammatory markers were high. His CNCA was positive. Sinus biopsy showed granulomatous inflammation with necrosis, and skin biopsy showed leukocytoplastic vasculitis. The diagnosis of granulomatosis with polyangiitis was made. During the ward stay, patient developed new fever spikes, confusion with progressive anemia and thrombocytopenia. Blood picture revealed microangiopathic hemolytic anemia with thrombocytopenia and high LDH retic count indirect bilirubin with normal coagulation screening. So the diagnosis of TTP, thrombotic thrombocytopenic purpura, secondary to an autoimmune process was made. The second case is Mrs. D, a 73-year-old female, presented with tiredness on exertion and lethargy for 2 weeks with a background of loss of appetite and loss of weight over 4 months duration. Clinical examination revealed pallor, tinge of icterus, a left-sided breast lump, but no lymphadenopathy or any organomegaly. Investigations revealed anemia, thrombocytopenia, and the blood picture showed leukoerythroblastic blood picture with microangiopathic hemolysis, elevated LDH, but normal coagulation screening. True-cut biopsy of the breast lesion showed invasive breast carcinoma. CT, chest, abdomen, pelvis didn't show any significant metastatic deposits. Bone marrow biopsy showed deposits of CK7 positive adenocarcinoma. A diagnosis of breast malignancy associated TMA was made. So in these 2 cases, although TMA is there, are we going to manage this patient in a same manner? We'll discuss this in the few minutes. So, what is TMA? It's an abnormality in the vessel wall of the arterioles and capillaries which lead to microvascular thrombosis with partial or complete obstruction of the vessel luminum. So the defining features are microangiopathic hemolytic anemia, thrombocytopenia, and organ dysfunction due to microvascular thrombi. So in the blood picture, you can see the red cell fragments, which are also called schistocytes, and we can barely see any platelets. And the biopsy specimen of the glomerular shows thrombosis of the glomerular arteries, arterioles, and the capillaries. So the TMA can be classified into primary TMA syndromes and systemic conditions which can cause secondary TMA or MAHA with thrombocytopenia. So the primary TMA syndromes would be thrombotic thrombocytopenic purpura, which can be a hereditary or immune-mediated, Chica-toxin-mediated HUS, complement-mediated TMA or HUS, drug-induced TMA syndromes, and prior causes of metabolism-mediated TMA. Systemic disorders which can present as TMA or MAHA and thrombocytopenia without systemic thrombosis can be a hypertensive crisis, malignancy associated, which I will tell detail in my talk. Pregnancy associated, there are conditions like preeclampsia and health which are peculiar to the pregnancy. But in addition to that, the primary TMA syndromes like immune-mediated TTP and complement-mediated HUS can also precipitate it, and the first presentation can be there in the pregnancy, especially in the second, third trimester and postpartum. Infections mediated, mainly viral infection, hepatitis C, HIV, CMV, COVID-19, and some fungal and bacterial infections can also cause especially MAHA and thrombocytopenia. Autoimmune disorders like SLE, scleroderma, deep renal crisis. In addition to that, catastrophic APS can also mimic the presentation of TMA. Transplant-associated TMA, mainly the hematopoietic stem cell transplant rather than the solid organ transplant, can cause transplant-associated TMA. So we'll first discuss about the primary TMA syndrome. First is the thrombotic thrombocytopenic purpura. So it is a Mojave moderate to severe thrombocytopenia with associated organ dysfunction. Commonly, what we see is the neurological dysfunction, but cardiac, gastrointestinal, and renal involvement can also occur. The presence of specific organ dysfunction is not a prerequisite for a diagnosis. If the diagnosis is confirmed by the severe deficiency of ADAMTS13 level, that is less than 10 international units per deciliter. So what happens in the pathogenesis of TTP is normally the ADAMTS13 is synthesized in the liver and it cleaves the von Willebrand factor multimers which are circulated in the bloodstream. So in TTP, there is deficiency in the ADAMTS13, either qualitative or quantitative or both, lead to reduced cleavage of the von Willebrand factor multimers and form platelet-rich thrombi in the microvasculature. So what happens is when the RBC passes through the microvasculature, it can cause mechanical destruction and microangiopathic hemolytic anemia will result. With the reduced flow to the organs, there can be hyperperfusion and associated organ dysfunction. So how are we going to classify TTP? It can be a hereditary because ADAMTS13 gene coding the gene coding ADAMTS13 can cause undergo genetic mutations and cause hereditary TTP, or it can be immune mediated. So usually IgG autoantibody directed against the ADAMTS13, and it is an inhibitory antibody, and also it increases the clearance of ADAMTS13, which causes qualitative and quantitative deficiency. So the clinical features due to thrombocytopenia, the patient can develop skin mucosal bleeding and retinal hemorrhage. Neurological features can be fleeting and variable. It can be a simple headache or confusion, but can be progressive encephalopathy or coma, fever and anemic symptoms. Due to hemolysis, patient can have jaundice and unconjugated hyperbilirubinemia, renal impairment, liver function abnormalities, and cardiac impairment like chest pain, myocardial infarction, cardiogenic shock, heart failure, and acute cardiac arrest can occur. Gastrointestinal symptoms would be abdominal pain, pancreatitis, or gut ischemia. So what are the investigations? In the full blood count and blood film, we can see the microangiopathic hemolytic anemia and thrombocytopenia. Usually the hemoglobin value is between 8 to 10 and platelets are severely reduced. Usually the value is less than 30. Because of the hemolysis, retic count is raised, LDH is increased, and haptoglobin is reduced. Coagulation screening, including fibrinogen, is normal. That is negative. According to the organ involvement, renal function, liver function, and cardiac biomarkers will be altered. To find out the etiology of TTP, we have to do the viral screening, HIV, hepatitis B, especially hepatitis B before we start the treatment of TTP, and urine HCG. The definitive investigation would be the ADAMTS13 assay, which assays the activity, antigen, and the autoantibodies, which is the specific investigation, but is not freely available in our setting. So in such patients, when the patient has clinically TMA, but which predicts the likelihood of having TTP, there are some scores we use, plasmic and French scores. In the plasmic score, we use simple investigations like platelet count, renal functions, and markers of hemolysis like indirect bilirubin, retic count, INR, and MCV. And in the patient history, we can ask for the previous history of cancer and any previous history of transplant. With this score, we can identify the patient who are more likely to have TTP among patients with TMA. It will help because on suspicion, we have to start the treatment because it's a medical emergency. So how are you going to manage this patient? If it's a hereditary TTP, we have to give the patient recombinant ADAMTS13. But if that is not available, we can use fresh frozen plasma. Immune-mediated TTP, on suspicion, we have to start the therapeutic plasma exchange. It should be ideally initiated within 4 to 8 hours of suspected diagnosis. And the Plex is done daily until the platelet count is more than 150 for 2 consecutive days. It reduces the mortality from 90% to less than 20%. Glucocorticoids also should be started on suspicion of TTP. IV methylprednisolone 1 gram per day for 3 days if there is severe neurological involvement or if the cardiac troponin I is very high. For other patients, we can give prednisolone and taper off according to the clinical response. Once the diagnosis is confirmed, we have to give rituximab. Earlier use was reserved for severe and refractory TTP, but with the new evidence, what they say is in the guidelines, it is recommended to use the rituximab once the TTP diagnosis is confirmed. For severe disease or refractory TTP, we have to give the patient rituximab if it is not given previously, and we can use the caplacizumab. Thromboprophylaxis once the platelet is more than 50. And although renal impairment is common, it is not very severe and rarely patient require hemodialysis. Few words about caplacizumab. It's a monoclonal immunoglobulin fragment which binds to the 1 Willebrand factor and prevents platelet binding to the glycoprotein 1B receptor. It is initially given as an IV bolus and then the subcutaneous injection daily for a median time of around 30 days, even after the therapeutic plasma exchange course is completed. It reduces the duration of thrombocytopenia, exacerbations, refractory disease, duration of hospital stay, and also number of plasma exchange procedures. The side effects is bleeding, and it can be managed with the 1 Willebrand factor concentrates. So 2 main trials, Hercules trials and Titan study, which has included patients with acquired TTP, and it has shown that caplacizumab is superior over placebo in reducing the duration of thrombocytopenia, reducing the Plex procedures, and also in primary endpoint like TTP-related death and the exacerbations. The next syndrome is the Shiga toxin-mediated hemolytic uremic syndrome, which comprises MAHA, thrombocytopenia, and renal impairment. Here, the renal impairment is more severe than TTP, and up to 60% require hemodialysis. However, any organ can get affected. Patient can present with neurological dysfunction, cardiac dysfunction, or even multi-organ dysfunction. Usually, the preceding bloody diarrhea is there, which lasts for about 5 to 10 days. The pathophysiology is the cytotoxin which are released by the bacteria, enter the gut and then through the bloodstream. It enter the bloodstream and causes endothelial damage. With it causes activation of the complement system and thrombus formation and causes microvascular injury and organ dysfunction. Shigella dysentery and the E. coli O157H7 strains are the commonest implicated organisms, but pneumococcus, salmonella, campylobacter, certain viruses also implicated in pathogenesis. Management is supportive. If needed, we can give red cell transfusion, platelet transfusion, fluid and electrolyte management, stopping the nephrotoxic drugs, and initiation of dialysis in selected patients. The indications would be same for any other causes, and provision of adequate nutrition. Eculizumab, the use of eculizumab is lacking in Shiga toxin-mediated HUS. Atypical HUS is again present with the same Shiga toxin-mediated HUS-like presentation, but lacking a preceding bloody diarrheal history. It is primarily a pediatric disorder, and positive family history is present in approximately 20 to 30%. All the genetic mutation is common. It has a low penetrance. That's why the positive family history is less. Usually, they have antecedent trigger in the genetically predisposed individual. Around 70 to 80% of the cases, they have the antecedent trigger. Either it can be a viral illness or a pregnancy, especially in the postpartum period. So it results from the loss of function variant of the regulatory gene, or a gain of function variant in the effector gene, which involves in the alternative complement pathway. So what happens is, because of the genetic mutations, there is amplification of the alternative complement pathway, which causes activation of the complement system and formation of membrane attack complex, which can cause endothelial injury and thrombus formation. So the treatment is, again, we have to give the supportive treatment. But in addition to that, eculizumab plays a role in the management of atypical HUS. So eculizumab is a monoclonal antibody which binds the complement protein C5 there, and it blocks its the cleavage and the activation of the complement protein C5, and thereby formation of the membrane attack complex is prevented. So the main important in eculizumab is the patient can develop severe meningococcal sepsis, but also pneumococcal and Haemophilus influenza infection. So those patients should receive vaccination before starting eculizumab. But this is an emergency, we can't wait for giving vaccination. So what we can do is we can treat the patient with eculizumab, stabilize the patient, and then we can give the vaccination. Dramatic improvements in the kidney function and possible improvement in the survival is noted in the case reports. Renal transplant is also another option in the treatment because atypical HUS patient can develop recurrent episodes and they can go into end-stage renal disease compared to Shiga toxin-mediated HUS. So in such patient, renal transplant is an option, and those who are at high risk for recurrence, we can give prophylactic eculizumab after the transplant. The next syndrome is the drug-induced TMA. So it can be either immune-mediated or direct toxic effect. In immune-mediated TMA, the drug-induced formation of antibodies which cause destruction of the endothelial cells, platelets, and causes microvascular injury and thrombocytopenia. Quinine, platinum-based drugs, and quatapine are the common examples. The direct toxic effect is thought due to decreased expression of the vascular endothelial growth factors. So calcineurin inhibitors, sirolimus, anti-VEGF inhibitors, interferons, mainly the chemotherapeutic agents are implicated in this pathogenesis. So renal involvement is common in drug-induced TMA. So the detailed drug history is very important in the management of drug-induced TMA because stopping the drug is the treatment. Here, the therapeutic plasma exchange has no role. In immune-mediated drug-induced TMA, we have to avoid the re-exposure for the lifetime. But if it is a direct toxic effect, the drug can be re-challenged in patients if there is a necessary. But the immune checkpoint inhibitors, which are commonly used drugs in the recent, which develop antibodies against ADAM-TS30. So therapeutic plasma exchange has a place in this setting. So we'll discuss about the secondary causes which can cause AHA. One common is a hypertensive emergency. So hypertensive emergencies are defined as severe elevations in the blood pressure, 180 to 180 upon 120 mercury millimeter, with associated new or worsening target organ damage. The target organs can be retina, brain, heart, large arteries, or the kidneys. It is the rate of the blood pressure rise is more important than the actual value of the blood pressure. So hypertensive microangiopathy is a hypertensive emergency in the setting of hemolysis and thrombocytopenia in the absence of other causes. This hypertensive microangiopathy frequently associated with macrovascular complications like renal and cerebral dysfunction. It is very important to identify this hypertensive crisis and hypertensive microangiopathy because the treatment is totally different. In hypertensive microangiopathy, marked activation of the renin-angiotensin-aldosterone system is thought to play a key role in the pathogenesis. With the angiotensin 2 production is activated because of the activation of RAS, and it is a potent vasoconstrictor. In addition to that, when the hypertension is very severe, there is deficient nitric oxide production, which is a potent vasodilator. Because of the imbalance, there is expression of the pro-inflammatory cytokines and endothelial dysfunction. It can cause platelet aggregation and vasoconstriction. In the biopsy, there will be fibrinoid necrosis with fibrin and platelet thrombi in the lumina of the vessel wall, luminal narrowing and intravascular fragmentation of the red cells with platelet consumption. So the treatment is supportive with the blood pressure control typically resulting in resolution. The American College of Cardiology and American Heart Association guidelines for the management of hypertensive emergencies suggest that the blood pressure should be controlled to a maximum of 25% in the first hour and to a target of 160 upon 100 mercury millimeter over the next 2 to 6 hours, and then to normal over 24 to 48 hours. But with the hypertensive microangiopathy, if there is associated aortic dissection or severe preeclampsia or pheochromocytoma crisis, then that needs a specific management. The final is the malignancy-associated TMA. So malignancy-associated TMA can occur due to systemic microvascular metastasis, which can cause MAHA and thrombocytopenia, because vessel obstruction by the tumor cells can cause the fragmentation of the red cells and also platelet consumption in the tumor embolic. It can also be due to widespread bone marrow infiltration with cancer or secondary necrosis. So most cases implicated are due to solid organ malignancies, primarily adenocarcinoma, gastric, lung, breast, and prostate cancers. But it can be due to hematological malignancies such as lymphoma, which made up around 8% of the cases. Bone pain at presentation, respiratory symptoms, abnormal liver function, moderate to severe renal dysfunction, and abnormalities in the coagulation screen are seen most frequently in cancer-associated TMA compared to TTP. A blood film can show leukoerythroblastic blood picture in addition to MAHA. Early bone marrow biopsy and cross-sectional imaging will help to expedite the cancer diagnosis if that is not already made. And treatment of the underlying malignancy is the mainstay of the treatment, and therapeutic plasma exchange has no role in the malignancy-associated TMA. However, the prognosis is very poor, with a nearly 50% mortality rate within the first month of diagnosis. Drug-induced TMA can also occur in patients with malignancy. So the history is very important because both TMAs have some different approaches in the treatment. Because in drug-induced TMA, we have to stop the culprit agent, and supportive measures like blood pressure control and renal replacement therapy if required. So going back to our cases, how did we manage this patient? Case 1 is the TTP, which is secondary to an autoimmune process. So we started the therapeutic plasma exchange, and also to cover both the TTP and also the ANCA-associated vasculitis, we started the immunosuppression with IV beta-prednisolone and IV cyclophosphamide. Case 2 was a malignancy-associated TMA. So the patient was referred to Apeksha Hospital for chemotherapy. So the summary is thrombotic microangiopathy develops in a wide range of clinical situations. High degree of suspicion is required for the diagnosis, and early therapeutic plasma exchange is life-saving in presumed TTP. Correct underlying diagnosis of the TMA is required to avoid unnecessary therapeutic plasma exchange procedures, and newer drugs offer hope for improved survival of patients. These are my references. Thank you.